Welcome and good day. It's my pleasure to introduce to you our next company this evening. What if there was a simple non-steroidal injection that could immediately relieve back pain, and that relief could be lasting, and that it could serve up to 40% of the population that comes in to be treated for back pain? Our next company is Aleeva Medical, and they are hoping to bring just such a product to the patient, to the physician, and to the payer. Let's run the video.
Hi, I'm Jeff Young. We invent the micro-invasive devices for instant efficacy. We sold IP to NeoTract, which became the standard of care for benign prostatic hyperplasia. NeoTract was acquired by Teleflex for $1.1 billion. Majority of back pain patients show no impingement. Irritants are made by these cells, then leak through an opening to cause a chronic pain. Our discs contain no blood vessels. Oxygen and nutrients in capillaries are diffused from end plates into thick discs. As we age, we calcify the end plates, blocking capillaries, resulting in shallow diffusion. These cells in mid-layer suffer chronic hypoxia and starvation. During hypoxia, these cells make lactic acid and inflammatory cytokines. During starvation, these cells consume the disc matrix called proteoglycans. Proteoglycans are essential to retain water. Depletion of proteoglycans form cavity to retain the lactic acid. The acid eventually leaks out to cause acid burn and chronic discogenic pain. The top and bottom layers are well supplied with oxygen, nutrients, and pH buffer from capillaries. And pH is neutral, while the mid layer is highly acidic. Photo 1 shows a young disc with swelling proteoglycans in the nucleus. Photo 2 shows a dry and sunken nucleus capable of storing lactic acid. The red arrow points at a healthy disc matrix near the end plate, being nourished by nearby capillaries. Photo 3 shows a hollow and degenerated disc. The fluid exchange conduit absorbs the lactic acid, then blood plasma from the top and bottom layers of the disc. The conduit acts as a sponge, absorbing and dispersing blood plasma to reestablish fluid exchange for long-term pain relief. Bicarbonate in blood plasma neutralizes the acid for instant pain relief. Oxygen stops the formation of lactic acid and inflammatory cytokines, and nutrients feed these cells to rebuild proteoglycans. The delivery device followed the discography needle to combine pain diagnostic with therapeutic in one visit. We were cautious to implant less than 7 centimeters of conduit into painful discs. Even so, pain relief was highly significant without pain med. Cadaver studies show 30 to 50 centimeters of conduit can fit into hollow discs. Additional conduit will likely further improve pain relief by occupying more of the cavity to neutralize most of the lactic acid. We propose a study to include MRI to show disc rehydration, nose scan to show diminished lactic acid and increased proteoglycans, and X-ray to show this height increase. FEC is novel and providing unprecedented benefits. It is also no harm done and compatible with all other interventions. Therefore, the FEC has a potential to become the first treatment of choice for relieving discogenic pain in 40% of back pain patients. Please feel free to contact me. Thank you very much.
Pretty incredible. Tonight's session is giving us, you, our audience, an incredible understanding of science, biology, technology, innovation, and business opportunity, all rolled up together. Thank you. That was very interesting.
Thank you.
Presenting on behalf of Aleeva Medical is Dr. Jeff Young. I've had the chance to speak with Dr. Young in the past and get to know his technology and the business direction very well.
Thank you.
Dr. Young, welcome to the pitch. and let's begin our questions. And this time, we're going to stick with Audrey as our first panel member addressing questions for Dr. Young.
Thank you, Tony.
Great, thanks, Tony, and hi, Dr. Young.
Thank
First,
I'm Jeff.
oh, Jeff,
Yes,
okay.
please.
I have to say, wow, and it sounds amazing, and I hope it works like you described, because I'm probably going to need it someday. But I'm interested to hear a little bit more about the study that you have proposed and where you are with that study and what the regulatory path beyond that study looks like.
We have done first of all, we have done the sheep study, 36 sheep in Colorado State under Simon Turner. That we have 3-month study, 6, 1 year, 2 year, and 3 year study. We use braided nylon suture, which is FDA approved, globally approved as the conduit. And because we know it works, because it has a capillary action, draw blood plasma, draw blue saline all the way up, whole blood, 15 centimeter from gravity against gravity, and blue saline 150 centimeter up. So we know that thing can really suck up a lot of water. And in sheep, we find no tissue reaction to it, probably because it is avascular. The body does not know what's going on in our disc. What's more interesting, the proteoglycans start to grow around the nylon filaments, beginning at 3 months into the filaments. By 1 year, whole thing is the proteoglycans grow around the filament. So we're thinking, can this be instead a conduit as well as a scaffold? Can it be if we implant enough braided nylon suture in it, more and more proteoglycan grow around it, and proteoglycan absorb water, increase the swelling pressure of the disc? Can we increase the disc height because of this scaffold is involved? The scaffold is a wick, and is a conduit, is a spigot for nutrients and oxygen to feed these cells which been starving for a long time and under acidic condition. So we correct the acidity of that in the disc, as well as a starvation inside the disc, to reverse the degenerative process, knock out the lactic acid, knock out the inflammatory cytokine. We don't take tissue out. We don't do incision, no tissue removal, just implant a braided nylon suture into the disc.
Makes sense. And how long do you expect the effects to last for a patient?
Braided nylon suture lasts, actually, in all the literature that we found, nylon suture being implanted in abdominal area, lasts 25 years and tests the tensile strength, no difference. So that's in the abdominal area. In the disc, it may be much longer, because the disc inside the disc has no enzymatic degradation, because it's inside the disc, so it may last forever. Of course, if it digests away for whatever reason, we can always implant another one. In addition, multiple disc degeneration is a problem for all of us, and we can treat one disc at a time. Let's say L5S1 gone bad, put that in. 3 years later, L45, we can put that one in. So basically, we will have repeat customer by treating one disc at a time.
All right. Well, thank you.
Thank you very much, Audrey. And Jeff, thank you for addressing Audrey's questions.
Thank you.
This time, we're going to go to Mike Sherman. Mike, this has been an intense study of biology, and you have a tremendously substantial history in spine surgery. So this is perfect thinking area for you to address.
Thanks, Tony. So Jeff, congratulations.
I appreciate
I'd like you to explain the product a little bit more. I'm having trouble understanding what the device is. I'm thinking it's you said a braided nylon suture, but is it a balled up type of thing that is placed in the disc as a mass?
No, no. And it is a kit. It can, initially, we do the discography, which is a spinal needle, and we put a spinal needle with a guide wire, and then take the discography needle out, push in a dilator, which is about 1 millimeter, and then we slide a cannula into the disc. The cannula has teeth to hold the conduit. Go into the disc. The cannula, the current design is 2.4 millimeter, and the improved version is going to be 1.4 millimeter, the outer diameter. And then we draw the dilator and put in the conduit needle through the cannula into the disc, and the conduit needle also has teeth. So as it go into the cannula, the cannula can hold on to the distal end of the conduit to allow the surgeon or the physician, pain intervention physician, to. I know this question will come up. How do I know we completely fill the hollow disc? And this is the procedure. And we push in the needle partially into the disc, twist a little, pull it out. So we have more suture inside the needle lumen. Push it in again, spiral, pull out, push in again, multiple times, packing the suture into the hollow disc. When the disc is pretty full, then the surgeon know, or the physician know, is pushing the needle in become more difficult. So he or she will slightly withdraw the cannula to create headroom for the needle to re-enter again. So at that point in time, cut the proximal end of the suture and deposit the rest of the suture in the needle, all of it inside the disc. Pull out the needle, pull out the cannula, put a Band-Aid, the sterile strip on the skin, watch the patient for 30 minutes, bye-bye, go home.
So you're pushing a rope, basically. You're
Yes.
packing essentially sounds like a 1.5 or 2 millimeter braided nylon suture into the disc space.
Correct.
So, and the idea here is that the device brings fluid in and provides nutrients to the disc that were being blocked by the sclerotic end plates.
Correct.
So how does that fluid get to the conduit?
The fluid at the top and the bottom layers of the disc, the blood plasma is coming down, roughly about 2 millimeter or 2 millimeter worth from above and below. So the conduit absorbs the lactic acid and build up to draw contact the top layer and the bottom layer to draw the blood plasma down. And the rest, we are doing thousands of compression relaxation cycle per day, so that the conduit act as a sponge, absorbing, dispersing, to reestablish the fluid exchange without using a motor. So the patient's daily activity is the motor to reestablish the fluid exchange, which is lactic acid, waste, oxygen, nutrients from the circulation. So basically, that is the concept of reestablishing fluid exchange. I hope that answers your question.
Yeah, no, I think it does. And you said you're using NosiScan
Yes.
to look at lactic acid versus proteoglycan content.
Correct. Okay. And
look, good luck. Good luck, Jeff. Thank you. Thanks, Tony.
Well, Mike, thank you very much for the questions, and Jeff, again, for your answers. Now, let's go to Dr. Scott Bruder to address your question. Scott?
So I had a couple of questions. In that deck, in the video, You made mention of breakthrough designation. Have you already applied and received breakthrough designation from FDA?
Not yet. We're in process of looking for a regulatory consultant which has a lot of experience on that, because we don't want to screw up. We need some expertise to go into FDA. Yes.
Let's talk about your approach though. So I understand the biology very well of what you're explaining. My concern, and maybe you can help explain this, is in those patients that are going to be symptomatic, they have Thompson grade 3, maybe 4, they have advanced Furman grade, and by putting this wick in there, and you can wick out the acidic environment, you are favorably undermining the catabolic activity. So you're reducing the catabolic activity.
Look, and if this cells it doesn't have oxygen and nutrients, of course they're not going to make anything. But if we supply the oxygen and nutrients into the disc, and this cells may well be making the matrix again. One more study, they discovered that the cells from degenerated disc actually using 2x or even 3x more oxygen than the normal cells. That tells us that these cells in degenerate disc is longing to recover itself to do something. So they are because they are lack of nutrient, lack of oxygen, lack of pH, so they're being dormant. And last one is degenerated disc actually have stem cells in them. They're dormant. They're not doing anything. So because of the harsh condition in our avascular disc, everything shut down, and continue to degenerate. The degenerated disc continue to diminish in this height between 3 to 5% per year until it's pretty much like a pancake, no go. So basically, because of all this information, I say, what's the worst outcome? We put this in. If it's doing wonderful, wonderful. If it doesn't, pull it out. No harm done. So those are our perspective.
Good luck. Nicely.
Thank you. Thank you so much.
Dr. Bruder, thank you for your questions. And Jeff, thank you, for addressing in great depth and enhancing our understanding of your technology. Let me say that pain management is a gigantic field of opportunity. Doing things fast, easy, inexpensively, repeatably, reversibly. This is the kind of stuff that we all look for. Spine pain management is one of the particularly difficult areas where solutions like you're talking about could have real promise. So audience, now it's time to ask you, what do you think? Is this company a game changer? Will the challenge to the standard of care be there? And where or is there really more work to do for this company? Robin Young, publisher of Orthopedics This Week, will present our poll. Robin, over to you.
Thank you, Tony. We polled our live audience, and here are the results. 7% of our audience think restoring spine disc health is a winner and a game changer. 7% think it could challenge standard of care, which, by the way, includes spine fusion surgery. And 46% think Aleeva Medical's technology of restoring the fluid dynamics of diseased spine disc is promising, but needs more work. Our audience, no doubt, is thinking about Aleeva's need for a large human clinical study and the PMA regulatory pathway. 36% say there's something here, but it's hard to see. And that's probably because this is not an implant nor major surgery. It's an outpatient intervention with a needle, which in the spine world is a little unusual. 4% think Dr. Young needs to go back to the drawing board. I hope you enjoyed this presentation. If you want more information either about Aleeva Medical or how to be part of the live audience for the pitch, or even if you want to present a new technology or company, please go to Orthopedics This Week. That's at www.ryortho.com. And finally, if you liked this view into the future of medicine, which is changing at an ever accelerating rate, then let us know by clicking on, of course, the like button. Thank you very much. And we'll see you again at the next pitch.